Continuing our sessions, today is our sixth session. It will be on anticoagulants, which we are commonly using in our medicine practice for many of the conditions. And for that, today we have a renowned speaker, Dr. Sachin Jadhav, with us to talk about this anticoagulants, particularly on the newer oral anticoagulants and how we can use them in the clinical practice. So Dr. Sachin is basically an experienced hematologist, a BMT physician with a very rich experience in all hematology as well as hemato-oncology and the transplant. He has done his initial part of training in the CMC Vellore, and then he has went up to various other British Columbia, Vancouver, London, UK to get more and more experience. Currently, he is a group head of Hematology and BMT Department of all over India in the HCG department. He also had various publications, papers on his name. But more importantly, he believes firmly in the hematology. He has very good and clear fundas and clinical hematology. He believes in a team group or group practice or to build a team for the development and progress of the hematology. So over to you, sir, for our further talk.
Thank you so much for that introduction. And most importantly, thank you to Dr. Sandeep Shah for this kind invitation. And it's always a pleasure to talk to postgraduates. This is my team. You know, this is our core hematology team. One of the things that I like to emphasize, especially to postgraduates, is nobody can say I do transplants or I treat hematology patients. It's always a team, including nursing, pharmacy, housekeeping, or various colleagues in different specialties in the hospital, our diagnostic colleagues. We all work together to provide whatever outcome that we can provide to our patients. I'm going to keep this practice oriented. A lot of this information is already there in your textbooks. So I don't want to duplicate something that you can easily refer to. I'm going to focus more on how that information in your textbook can be translated into practice and what are the current treatment guidelines. So, you know, all of us are aware that whenever a clot forms in a blood vessel, essentially what is happening is blood vessels are nothing but pipes. They are pipes through which blood flows throughout the body. Heart is like a pump. It pumps the blood into these pipes, and the pipes are very smooth. Blood has to flow in a smooth manner so that there is no resistance and there is a steady stream of oxygen, nutrients, immune cells across the body. For this smooth flow, the blood has to remain liquid. You can imagine that if in any part of any pipe in the body, if the blood turns into a jelly, then the flow will be stopped. And that is essentially what happens either in an arterial event or in a venous event. Having said that, the body has an amazing system whereby wherever required, liquid blood can be converted into a solid jelly. And if you try to think why has nature given us this system whereby a liquid can convert into a solid, the logical thought that comes in our mind is to prevent spillage, to prevent this liquid from spilling out of the pipe. So obviously, if there is an injury, if any pipe in the body which is carrying this blood, whether it's an artery or a vein or a tiny capillary, when that is injured, when that is cut, first of all, that pipe will constrict. It's beautiful, right? The blood vessels have muscles in the in the middle portion of a cut vessel, which we have seen in anatomy. There are smooth muscles, and these smooth muscles will lead to vasoconstriction. First of all, whenever any pipe is damaged, the blood vessel will constrict, and then platelets, which are like pellets, they are like balls, they will go and they'll stick to just that part. The platelets will stick to that part and plug that injury so that blood does not spill out, so that hemorrhage is controlled. This platelet then forms a substrate, it forms a surface on which proteins start getting attached. And these proteins form a mesh, they form a fibrin mesh in which other blood cells get trapped. And thus, this entire clot plugs the vessel injury and thus prevents bleeding, hemorrhage from a cut pipe. So we understand these three steps. The vessel constricts, the platelets stick to that injured part of the endothelium, and they then form a surface on which other proteins, which are the coagulation proteins, they stick, the coagulation proteins, and they form a fibrin mesh, thus entrapping the other blood cells and forming a nice strong clot, thus preventing hemorrhage. I am sure you are aware of this coagulation cascade. What is obvious is it's not one protein which causes a clot. It's a series. There is one protein which gets activated. This will activate the next one and the next one and the next one and the next one until fibrinogen converts to fibrin. And this coagulation cascade was described a few decades ago. And as physiologists and researchers realized that there is this cascade whereby, like a waterfall, one protein gets activated and leads to another activation of another protein, ultimately leading to that thread, that fibrin, which will then create a mesh forming a clot. Now, with ongoing research, it was found that there is this extrinsic pathway, intrinsic pathway, and a common pathway. Both ultimately merge and they form the same thread, which is the fibrin thread. A fibrin monomer becoming a polymer and then eventually creating a mesh, which will create a clot. But as time went by, researchers also found out that there are problems with this model of coagulation. Yes, we can test this model with an APTT and PT. We can check the various proteins, we can check the pathway, we can test whether the coagulation proteins are present in adequate amount, and thus try to understand whether a patient is deficient in a protein, which can lead to bleeding, or excess of another protein, which can lead to unnecessary clotting even without a vascular injury, right? So yes, we can do that. However, there were challenges. There were some things which were not explained. For example, why is it that in factor 12 deficiency, which is supposed to be the first protein, right? Factor 12 is supposed to be the first protein which will trigger this pathway. Why is it that in patients who are deficient in factor 12, there is no bleeding? Why is it that if a patient has hemophilia A, although there is factor 9, why doesn't factor 9 compensate for the lack of factor 8? What actually happens in hemophilia B? Where does calcium play a role? What happens to this intrinsic, so-called intrinsic pathway in human biology? What exactly happens? And much of this was not explained with this old model of intrinsic and extrinsic pathway of coagulation. What was instead figured out that it does not work like this. It really doesn't work like this. And then this same sequence of events has now been restructured. And today we understand that the coagulation pathway is not necessarily the cascade the way we used to learn earlier, but now it is called as the cell-based theory of coagulation, the cell-based theory. Now, this cell-based theory is kind of what I told you a few minutes ago, that the platelets stick and the platelet create a surface on which they initiate clotting, right? So the platelet, once the platelet is activated, it expresses what is called as tissue factor. And I think this is a beautiful system because now the entire clot gets concentrated on the platelet. The clot does not float in the blood because a floating clot is useless. The clot has to be concentrated and stuck at that area where there is injury to the vascular endothelium. So this is how the cell-based theory tells us that a clot gets localized. And this is important because we will see how later when we look at abnormal clotting, when we look at clotting in the deep venous system or the arterial system, how that clot sticks to one place and then it can break and embolize distally and create problems. But everything starts with this first step, right? So this vasoconstriction, there is a platelet plug formation, and the platelets then create a surface which has tissue factor. And this tissue factor then binds to 7A, leading to the other sequence of events which we have studied until now. This is how the clot is initiated. Once it is initiated, it has to be amplified, right? There is something called as chain reaction. That means 1 leads to 2, 2 leads to 4, 4 leads to 16. So the clot is amplified. It attracts more platelets and there is a greater tissue factor bearing surface, and the clot actually starts multiplying over the platelet surface. Of course, this tissue factor bearing cell is the platelet and the vascular endothelium. I'm sorry, it's not really the always the platelet membrane, but the vascular endothelium which expresses tissue factor. And then the platelets serve as the second surface on which the clot is amplified. This amplified clot is then propagated on the activated platelet, and then it forms a nice, tough clot. Problems happen when this clot happens without an injury, or there is an injury and it leads to a clot which persists for a long time. What that means is the body has a counter regulatory mechanism. The body has created a counter regulatory mechanism. There is one mechanism for building the clot, and there is a second mechanism for breaking the clot. So the clot has to dissolve. As the vascular endothelial injury heals, the clot has to dissolve so that blood flow can be reestablished. And if the clot is in an artery, that artery can again start providing blood to its target tissue. Or if the clot is in a vein, the clot will dissolve and it will again allow the backflow of blood from the tissue towards the right side of the heart. This thrombosis, abnormal clotting, if that happens, it can lead to serious damage. And that is where today's topic comes in. What we try to do as doctors, as physicians, is when we get a patient who has an abnormal clot, typically in a vein most commonly, right? And you want to break that clot because you want to establish the blood flow again. We use pharmacologic methods. We use chemicals which are essentially drugs. And these drugs can then affect the clot and prevent the further propagation of clot so that normal fibrinolytic mechanism can then dissolve it. And as normal fibrinolysis is dissolving the clot, fresh thrombosis is prevented. Now, if I had to, and I'm sure all of you, if somebody asks you that how can you prevent propagation of a clot, and we go back to the cell-based theory, you can see that the last two proteins are factor 10 and factor 2. So if you can create inhibitors to these two, you can stop the propagation of the clot. You see, so this is why it is important to understand the cell-based theory. Ultimately, if we hit the last step in clot formation, either by blocking factor 10A or factor 2, we can prevent the propagation of clot. And that is exactly what has been done. That is exactly what has been done. Drugs were created, and one of the first drugs that we've all read when we were doing our second MBBS, when we were doing pharmacology, was heparin. And heparin is this molecule here, right? This is just one word amongst all of these different names. But what is interesting to me is heparin was discovered when a medical intern, somebody like you and me, when a medical intern minced liver, he crushed the liver and he used the extract of the liver and found that when that extract was put in blood, it prevented clotting. And because this extract was from liver, which is hepar, he named the drug as heparin. This tells us many things. Besides the fact that, if we are inquisitive enough, we can discover how biology works. And that eventually may lead to therapeutics, that eventually may lead to us discovering a new molecule, a new protein, a new drug, and saving lives. That's the first thing that we learn from this story. The second thing that we learn from this story is the liver is an important organ in coagulation, right? The liver is an important organ. The liver is a phenomenal organ. It's a factory of chemicals. The liver accepts toxins from the gut and detoxifies them. The liver creates new proteins, new molecules. Some of them are coagulation proteins, right? And it then secretes it into the circulation. So the liver is this chemical factory which is making almost all the coagulation factors, probably except von Willebrand antigen, if I'm not mistaken. Maybe Parimal can correct us at the end of this talk. So the liver produces heparin, and not only heparin, it also produces all of these coagulation factors. What we also understand is if we give some medicine, it's going to cause side effects on the liver. So we try to think of these things when we think of medicines which can be used to break a clot or prevent a clot from progressing further. Now, let me finally come to this slide, which was published in 2010. You see, just 10, 11 years ago. And at this time, you see there are some drugs which were called as established anticoagulants. And starting from heparin, raw, unfractionated heparin, to low molecular weight heparin, which is nothing but processed heparin. You take this heparin and you break it into low molecular weight heparin. And then there were some other drugs. And then we knew that vitamin K is important for making coagulation factors. So if you antagonize vitamin K, if you give a medicine which will stop vitamin K from doing its job, then you can stop the production of 4 coagulation factors. And these medicines can then prevent clot formation, right? So these were the established anticoagulants around 2010. Most of them are natural. However, a lot of work was going on to create newer molecules, newer chemicals, newer drugs, which are designed to give a specific action with minimum toxicity, right? So all of us want to give treatment which is effective with minimum side effects, correct? Now let's see what exactly are these drugs. And it is fascinating for me that in these 10 years, all of these so-called new anticoagulants are now becoming routine part of our medical treatment. And you will see how. Can you see the slide moving?
Yes.
Okay, thanks. So let's start with some of the oldest drugs. Like I said, there were drugs called warfarin. They were called the coumarins. And the two commonest used coumarins were warfarin and acetylene, and they are still in wide usage. The old medicines, very simple chemicals, easy to make, and hence cheap. They've been there for donkey's years. And these vitamin K antagonists, when you give these drugs, they are beautiful. They will stop vitamin K from doing its action. They will stop the production of vitamin K dependent coagulation factors, and thus they will become what is called as a blood thinner in such a manner that the blood does not clot. But there was a problem. There was a serious problem because these were oral medicines and they had a lot of drug food interactions. So for example, I remember, and I'm sure you all have experienced this. You see a patient who's taking, say, 5 milligram of warfarin. You do her PT-INR today, and it may be, say, 2.2. Same patient, same drug, taking it properly. You repeat the PT-INR after a week, it may have come down to 1.6 or it may have gone up to 3. So this drug did not have predictable action. The action varied on the food that the patient would take. So suppose on a day, a non-vegetarian patient has, has chicken liver, which has a lot of vitamin K. That burst of vitamin K goes in the blood and it nullifies the action of warfarin, right? So there were many such drug and drug food interactions leading to unpredictable efficacy and also unpredictable side effects. For example, patients may then have very high INRs, putting them at a risk of serious life-threatening intracranial hemorrhage or gastrointestinal bleeding, right? And thus we had to regularly monitor the dose. It was crazy. Patients would ask us, doctor, why is it that my INR goes up and down? And we would try to explain to them. Then there was another problem that majority of the labs do not do INR in a proper manner. You can't trust the report. And where in this massive country of ours are we going to be able to standardize the lakhs of labs in this country to give reliable PT-INR? So there were multiple challenges. And although these medicines were cheap, although these medicines were dirt cheap, pennies, rupees for paise, the PT-INR testing was expensive and then repeated blood tests. So that was the limitation of vitamin K antagonists. Nevertheless, those were the only medicines which were available. Those were the only oral anticoagulants which were available. So a lot of research used to go in, and literally every week or, every month, the hematology journals would have some paper trying to understand, some research which was published trying to understand how do we ensure that our patients get a reliable dosing so that they don't get a repeat clot, neither do they get life-threatening bleeding, two extremes. So there were some genotypes which were identified, which could guide warfarin dosage. Who can do genotypes? I mean, not even in the US can every patient be genotyped. There was a lot of data, and there were some coagulation clinics or thrombosis clinics or thrombophilia clinics in certain referral centers in the world which could do genotype. And there were softwares which were created based on the genotype and based on the patient profile, trying to predict the efficacy and try to reduce the problems with vitamin K antagonists. But all of this was very challenging, right? And thus there were further studies which were done, which actually showed that even if you do genotyping, it has very limited utility in real life. And even those centers which had the facility to genotype the genes which are present in vitamin K metabolism. Even if you can genotype those, you can't really predict. It doesn't really help in patient treatment. And that's where newer drugs were being worked on. And what were called NOACs until 5-10 years ago, that is new oral anticoagulants, are now called DOACs. That means direct oral anticoagulants. And these were designed in such a manner that you don't have to check an INR, you don't have to check an APTT like we had to do for heparin. I remember when I was doing my residency, we didn't have super specialists. So we used to manage AMIs on our own, medical residents. And we would give streptokinase because only streptokinase was available. And we used to give unfractionated heparin. And APTT had to be done every 6 hourly. But our lab didn't do APTT. So I used to do a clotting time every 6 hourly, right? So for heparin, you had to check APTT or a clotting time. For vitamin K antagonists, you had to check a PT-INR. We needed drugs which did not require ongoing monitoring, which had very few interactions. And hence they had predictable dosing. You give this dose and it will give the effect. And you can also determine what is the risk of bleeding or the risk of recurrent thrombosis if you're underdosing. So you could give a fixed dosing, right? And that was the aim. So these are designer drugs. And if we compare these newer oral anticoagulants with the vitamin K antagonists, well, this is what it is. Like I said, they should be able to work quickly, fixed dose, no drug-drug or food-drug interactions or minimum food-drug interactions. You don't have to monitor, and you should be able to stop it and reverse the anticoagulant effect. So with these thoughts in mind, these drugs were created. So like I said, there are two kinds of these drugs, those which are direct thrombin inhibitors, right? And those who are 10A inhibitors. So like I said, 2 and 10A, the last two proteins in the coagulation pathway. It's a bit easy to remember the name. The 10A inhibitors have XA in their name. So there's rivaroxaban, apixaban, endoxaban. Yeah, different chemicals. The direct thrombin inhibitors are the trans. So there is argatroban, dabigatran, etc. etc. So unlike vitamin K antagonists, which would affect the 4 vitamin K dependent coagulation factors, the newer ones only act on 1. Either they'll act on 10A or they'll act on 2. So direct thrombin or anti-10A 10A inhibitors. And since they work on only one single step of coagulation, work on one coagulation protein each, they are predictable. Now this chart kind of tells us some more details about these drugs. It tells us that yes, there are thrombin inhibitors and there are 10A inhibitors. Like I said, 10A have the XA in their name. There is rivaroxaban, apixaban, and endoxaban. Yeah, and they are taken orally, so no injections. But at the same time, there should be no interference with food. At the same time, there should be predictable bioavailability. The half-life should be narrow, predictable. They should work quickly. So for example, we had to use in the past, if a patient presents with a deep vein thrombosis, you had to use heparin for a quick action for 5 days. And along with that, give a warfarin, because warfarin would take 5-6 days to reach optimum anticoagulant action. It would take few days. However, if you look at these drugs, they are designed to have maximum plasma concentration within a matter of hours. So they have to work quickly. But of course, like any chemical, either these are metabolized by the liver. Remember, liver metabolizes toxins. So either there are drugs like rivaroxaban and apixaban, which are metabolized by the liver, or they are excreted by the kidneys. Now, this is important. And thankfully for us, either it is this or that. So if there is a drug which is excreted by the kidneys, you know what else you can use in a patient with renal failure. You don't have to use dabigatran. You can use another drug which is actually not excreted in urine. At the same time, if you have a patient with, say, Budd-Chiari syndrome, right? Budd-Chiari syndrome with deranged liver function. In such a patient, don't use rivaroxaban, don't use apixaban. You can use something else which has minimal metabolism in the liver, right? Now, also because these are designed, they have minimum side effects, so they don't have dyspepsia, etc., etc. Dosing has to be once or twice daily at most. So you can see these are beautifully engineered medicines. Now, coming to, just a minute. Coming to reversal, fine, a patient has an abnormal clot. You want to bust that clot. You want to give something that will either break the clot or prevent clot propagation. What if you end up overdosing? Then the patient could actually have a life-threatening hemorrhage. So you should be able to reverse the medicine. In the older times, it was very simple: heparin, protamine, very predictable reversal based on the dose of heparin that you have given. For 100 units of heparin, you give 1 milligram of protamine, and we used to get protamine injection vials. Low molecular weight was a bit difficult because dosing was not very clearly based on the dose of low molecular weight heparin you have given, but still, it could be done. With the newer drugs came newer problems. How do you reverse this drug? Do you have uh, uh, I think Dr. Apurva Patel has raised hand. Dr. Apurva, do you want to ask a question? I'll be happy to take a question. Dr. Apurva? Okay. Feel free to stop me in between and ask questions if you like. We don't have to wait till the end for a question answer session. So now, because these are chemicals and they work on a particular coagulation protein, it's difficult to give something that will reverse the effect. Having said that, what we can do is we can give an overdose of coagulation protein. So suppose if somebody has had a newer oral anticoagulant and is bleeding, and you don't really know what to do, either you can use certain types of dialysis to chelate out the drug from the blood so that the drug can be bound and chelated out in the dialysate, or you could give an overdose of coagulation proteins to stop the bleeding. And we do that by giving FFP. Remember, fresh frozen plasma is essentially a concentrate of coagulation proteins. It has everything. Fresh frozen plasma has every coagulation protein that is required for clot formation. So if you just want to give a blind overdose of coagulation proteins to stop anybody's bleeding, you can give FFP, right? And these are the certain mechanisms of reversal of anticoagulant effect. Now, after this brief primer, I hope I didn't bore you too much, of a basis of these drugs, how these drugs were designed, what is the thought process, where do they work in the coagulation pathway, how do they affect the biology and cause the therapeutic action. Now we will go to the actual application. Does anybody
Sir,
ask a question?
sir, one second, sir. This is Dr. Srinivas here.
Yeah.
Sir, that what is that FEIBA, sir? That in the previous slide
Oh,
we have
FIBA.
talked.
Yeah. Okay, that's a good question. So I skipped it. So FIBA is factor 8 inhibitor binding activity. It's a drug made from plasma, And we use it for patients who have hemophilia. It's called FIBA, FEIBA. What is done is there is something called as a prothrombin complex conjugate. It's a concentrate of some key coagulation factors which are activated. Now, FIBA is a wonder drug. It will clot blood. It will clot anybody's blood. It will even clot the blood of a patient with hemophilia. There are two such drugs which are widely available. One is FIBA and second is recombinant factor 7A. These two products are so strong that you put it in blood, you give them to anybody, the blood will clot. So anybody who's bleeding, if you don't know what's happening, you can of course give FFP as in coagulation proteins, but you can give FIBA or recombinant factor 7A to just clot the blood, no matter what is the cause of bleeding. So that's FIBA. That's a good question. Sorry,
Sir,
yes.
it's a non-specific one, right? It is like it doesn't block the thrombin or 10A. Like
Yeah.
we are not specifically acting on those things. It will just is a non-specific one.
Yes, you're right.
Okay. Yeah. Thank you, sir.
You're welcome. Thanks for asking that question. So now let's go to the application. How do you apply? And if you try to, research, the data is very confusing. We need to understand that, fortunately, unfortunately, a lot of medical research is funded by pharma industry. And thus you will find very detailed, specific research for atrial fibrillation, for stroke, for deep vein thrombosis, etc., etc. And sometimes it's difficult to apply it to practice because that research study might have been funded by a company for one specific drug that they are trying to market. So it's very difficult to make sense of what drug to use, when to use, etc. And that is when I typically go to a guideline. And nice guidelines are published by a regulatory body in the UK. More than a regulatory body, they create guidelines for doctors, which can then be implemented into practice. Easy to use guidelines. So let's see, how do we use these anticoagulant drugs for a patient who has deep vein thrombosis or has pulmonary embolism. You will see three kinds of acronyms in this talk. There's DVT, which is deep vein thrombosis. There is PE, which is pulmonary embolism. And then there is VTE, which is just venous thromboembolism. It's like a basket term for DVT or PV, venous thromboembolism. So those are the three acronyms that you're going to see. Now, how do we reach the diagnosis of VTE, venous thromboembolism? Can any one of you tell me how does a patient of deep vein thrombosis of the leg present? Anyone?
Sir, with swelling of the lower limbs and pain in the lower limbs.
You're right. And why does that happen? It's very logical. Like I said, these are essentially pipes. The blood vessels are pipes. And the venous system is responsible for taking blood away from a body part towards the heart. So if there is a blood clot in that venous system, in that pipe, the venous flow is obstructed, leading to a backlog of blood, leading to swelling of that part. So there is leg swelling. If the VTE is in an upper limb vein, there is swelling of the hand, right? And if the VTE is in a cortical venous sinus thrombus around the brain, then there is cerebral edema. So there's swelling, there's pain, depending on the site of the clot. I told you some time ago that the human body has a fantastic system of breaking the clot on its own. And when that clot is broken, you get strands of a protein which can be tested by a test called as D-dimer. So if D-dimer is elevated in the blood, it means that there is a clot somewhere which is being broken. And it is that broken residue of the clot which you are measuring in a D dimer. So let me give you an example. Suppose you have a patient with pulmonary embolism, and if it's a tiny pulmonary embolus in one of the peripheral arteries, right? That clot is so small that when it undergoes fibrinolysis, it is not going to produce enough D dimer so that it can be measured in the blood assay. However, if the clot is, say, in a second level pulmonary artery, right? A reasonably big pulmonary artery. So it's a reasonably big clot. Now, when that clot undergoes fibrinolysis, it will produce enough D dimer for your assay, the blood assay, to show that the D dimer is high. So the beauty of this D dimer is it will only tell you about significant clots. It will not tell you about tiny clots because they anyways don't need any treatment. So the first thing that you will do when you're suspecting venous thromboembolism usually is a D dimer. Remember, D dimer can be high in other conditions as well, such as DIC, because in DIC, say secondary to sepsis, there is disseminated intravascular coagulation. So there are small clots across the circulatory system, and you are not really having one big clot causing a VTE. So you have to know what are the false positives for D dimer. If it's in a leg or abdomen or pelvic veins, you can always do a Doppler to actually look at the clot, which is blocking the flow of blood. If the clot is suspected to be in the lungs, you can do a CT pulmonary angio, which is extremely good, sensitive, specific, fantastic test. However, for a CT pulmonary angio, you need to give a contrast which has renal excretion. So if you have a patient whose kidneys are fired, your creat is high, and you can't give the contrast to have a CTPA, you can do a nuclear scan, which is a ventilation perfusion scan. I'm sure you are all aware of this, but I'm just passing through this before we reach the the treatment part of it. Quite often, you're not sure whether you should do these tests. Either the patient does not have full-fledged signs and symptoms, or patient is not stable enough. Somebody is on a ventilator and you're suspecting pulmonary embolism. Are you really going to shift a patient on a ventilator in an ICU to the CT scan to do a test? Or the patient does not have the money. They say, doctor, are you sure you want me to spend on this? How sure are you that I have a venous thromboembolism before you make me spend on this test, or before you move a patient from the ICU to the radiology CT suite? And that's where scores like the Wells score come in place. These scores, they help us. They give us a condition with a point, and depending on how many criteria a patient is fulfilling, you add up the points. And then depending on the points, you can kind of say, well, deep vein thrombosis is likely in this patient. Hence, I want to do this test, whatever it may take. Even if the patient has to spend, I will try to convince the patient because DVT is very likely. However, if using a score like Wells score, you find out that, well, the likelihood of my patient, this patient, having a DVT is low, I will say, well, let's wait and watch. The other use for such a score is to start immediate anticoagulation. Sometimes you don't have the time. Sometimes you have to start treatment immediately before the diagnosis can be confirmed. And again, such a score helps us. So if the score is low, you don't have to rush into starting anticoagulation. You can wait. Maybe you can repeat the test later, right? So this score has two applications. One, to decide which patient to really go ahead and test, and two, whether you want to immediately start anticoagulation. Somebody raised their hand. Feel free to ask a question.
I think you can go ahead.
Okay, fine. Now, once you suspect venous thromboembolism, you look at a score, you're sure that, well, it's likely. I want to go ahead and do the tests, and I may even start interim therapeutic anticoagulation. Pending the results of my definitive diagnosis, I will start anticoagulation. I will do the scans, I'll diagnose, and then continue treatment or stop treatment. At the same time, if the scan is negative, but I really suspect VTE, I can do D-dimer or I can repeat the scan again. So that's how we, put multiple things together to diagnose and take therapy decisions for patients. Something similar applies to, the diagnosis and initial management of pulmonary embolism. Based on your suspicion, if the score is high and you're thinking of pulmonary embolism, start interim anticoagulation. If possible, do an immediate CT pulmonary angiogram. If positive, continue anticoagulation. If negative, either you stop anticoagulation or you repeat the test until you're sure that your diagnosis is correct. So now that you've achieved a diagnosis, you have a basic understanding of the various drugs which are available. How are you going to choose which drug to start? And do you want to do any more tests before you actually start anticoagulation? Yes, you need to do a full blood count. Do you know why? Can anybody tell me why you should do a full blood count as a baseline before you start anticoagulation? Anyone?
Platelet count before, in case we get hit later.
Very good. Also, the patient may have low platelet counts at baseline, which might make you feel that, hey, I don't want to give full anticoagulation, or I have to give, along with anticoagulation, I also have to give platelet transfusion. Otherwise, there will be, bad bleeding. So you need to look at the platelet count as a baseline and also to track whether the patient develops hit later on. First. Second.
Sir, there is something called like we have this corona score, right, sir? For that,
Yeah.
In that score, there is a TLC, a total leukocyte count, absolute I remember it as absolute neutrophil count and platelet count are one of the risk factors which are high in the baseline. If they are high, they will count it as a one score each, like that.
Yeah, I agree with you. Although I am not, conversant with COVID management.
Sir, it's a corona score, sir. Like it is a name of the score for in cancer patients for solid tumors. They have given some score like
you're
that
talking
where
of
we can
corona
start.
score. Oh, corona
Yes, sir,
score. I thought
corona.
you're talking of corona. Okay. Yeah, corona score, of course. So for cancer-associated thrombosis, corona score is a very good predictive score. And thanks for bringing that up. There's another thing. Do you know that patients with who are severely anemic, I'm sure you are aware that they have a bounding pulse, right? Do you know why patients with anemia have a bounding pulse?
Sir, there will be decreased what you call oxygen carrying capacity. So there will be increased this thing to compensate. So there will be bounding pulse like.
Yeah, there's hyperdynamic circulation. So you can imagine the heart is pumping hard. And in patients with anemia, the hyperdynamic circulation can actually lead to capillary bleeding. So it's not only the RBC, the WBC and the platelets and the coagulation and the PT and APTT that we are looking at. We are also looking at hemoglobin. You need to optimize the blood so that you don't have unnecessary bleeding. LFT creatinine, obviously, because like we spoke, based on the metabolism of the drug, you'll have to choose if there is liver or renal derangement, what drug to use. And you do a baseline PT-APTT, it tells you, it gives you an indication of what's the baseline PT-APTT if you have to monitor it further, a bit dependent on the, the older drugs. or if there is a lupus anticoagulant, in which case your PTAPTT will be deranged. So you do these blood tests at the baseline. But remember, you can always start the drug, take a sample, send it to the lab and start the drug. You don't really have to wait for the results. The first dose can be given. We take into account the contraindications, like I said, the liver, kidney, etc. We take into account whether the patient has a site of bleeding. So for example, the patient has had a fracture and has come with a fracture femur and lying on the bed. And because of being immobile, there is DVT. What are you going to do? What if there is bleeding? What if there is a surgery plan? How are you going to manage? That's why you need to know the comorbidities and the other issues. Then there is patient preference. The patient may say, doctor, I don't want to get admitted. Every now and then we find a patient who says, I don't want an injection, or I don't want to do the blood test repeatedly. I want an oral drug. So we also take into account the patient's preferences. Now, how long should we give anticoagulation? You started interim anticoagulation, you have done your scans, you have established the diagnosis of ET. How long to give? We know that we should give for at least 3 months. You could extend from 3 to 6 months if there is an ongoing cause for thrombosis. So for example, there is ongoing active cancer, right? Or immobility. Then you can extend beyond 3 months, 3 to 6 months for an established clot. We are not talking of prophylaxis here. We're talking of therapy. Okay. Do we give it beyond 6 months? Suppose if every now and then we see a patient who had DVT 9 months ago, received some anticoagulant, and now the treating physician sends to us saying, Dr. Sachin, tell me, when do I stop? And then the patient comes with a second venous Doppler showing that clot is still there. It is not fully canalized. Should we continue? Should we stop? Nobody knows. There is no data to guide the duration of therapy, or rather there's conflicting data. And sadly, this is something that you have to individualize depending on the risk factors that the patient has for recurrent or progressive thrombosis. You can decide to extend beyond 6 months, but minimum 3 months of anticoagulation is required. Now, there are some key things, right, that we need to know. And there are 4 or 5 things that you need to know. If we have somebody with a life-threatening pulmonary embolism with hemodynamic instability, that means the blood pressure has dropped. You need to bust that clot immediately. So this is the only indication for thrombolytic therapy in venous thromboembolism. If you want to use urokinase or the newer, drugs for fibrinolysis, in PE, we use it only when there is hypotension, hemodynamic instability. There may be a big thrombus, but if the blood pressure is good, you don't have to do thrombolysis. Similarly, for the newer drugs, where there is a fixed dose, you have to be careful in patients who are very lean, underweight, or overweight. The dosing may be different. You may have to figure out what you're going to do. Similarly, when we used to initially start warfarin or acetrom in the past, we used to try to coach the patient that you can self-monitor. If your INR goes beyond this, you reduce the dose by so much, or if it drops below 1.5, you increase the dose by so much. But we were always scared, right? We were scared. What if this patient doesn't check the INR and doesn't alter the dose properly? And NICE guidelines are very clear. Do not expect self-management, self-monitoring, and self-adjustment of doses by patients. It's too dangerous. So what the NICE guidelines say, right? And we have most of the drugs that NICE guidelines recommend. And you can say that now nobody is talking of heparin. Nobody is talking of low molecular weight heparin. Nobody is talking of warfarin. Nobody is talking of acetrom. So today, if your patient can afford, and probably most of the patients can now afford, because we have generic DOACs. We have generic direct oral anticoagulants, direct acting, right? So garden variety patient, no renal impairment, no active cancer, no Apla syndrome, no hemodynamic instability, which will necessitate a thrombolysis. you can use one of these two. In fact, current guidelines do not routinely recommend any type of heparin or vitamin K antagonist. Okay. And if you can't do this, then start with an LMWH for 5 days and follow it up with a VKA or one of the newer drugs. If you're using VKA, stick to an INR of 2. Now remember, these guidelines are for venous thromboembolism. They are not for atrial fibrillation. They are not for stroke prevention. They are not for prosthetic cardiac valves. Those are different guidelines, and we are not going to touch upon those in this talk. If there is renal impairment with very low renal function, go back to the older drugs. They are safe. Use unfractionated heparin or low molecular, but with low molecular, we have to do anti-10A levels when there is renal impairment. You can use vitamin K antagonist, cheap and effective, but requires stringent monitoring. What to do when there is an ongoing problem such as an active cancer, which can lead to a risk of recurrent VTE, right? Somebody who's been diagnosed with cancer in the past 6 months or has current untreated or inoperable solid tumor, consider oral anticoagulant. It's easier to give fixed dose. Already the patient is dealing with a cancer. They don't want to come regularly for your PT-INR, right? So continue the newer direct oral anticoagulants. And if you can't do those, of course, there are the older heparin and VKAs. Give it for at least 3 to 6 months, like I said before, and take into account the tumor side. Now, let me give you an example of this. About 2 months ago, we had a patient with CS stomach, a bleeding CS stomach, right? And this patient had, if I remember correctly, a pelvic vein thrombus, and she was terminal. And we used one of the oral anticoagulants, the direct oral acting oral anticoagulants, and she bled, and the hemoglobin dropped, and she had to be readmitted and blood transfusion in a patient who was practically palliative. So this was a tumor site which had a very high risk and a real bleeding from the CS stomach site. So what do you do? At this time, we took into account the fact that there was a very high bleeding risk, and this was a palliative patient. We did not have the predicted survival was not very high. At that point, after multiple discussions with the treating oncologist, after multiple discussions looking at the drugs, the anti-cancer drugs which are going on, looking at the bleeding risk, we actually decided it is not worth giving a drug which is causing more harm than good, which is causing bleeding. And we actually chose not to give an anticoagulant for this patient because the predicted survival was less than a month or 2, right? This was really not going to help her. So you have to really look at the whole patient and not just focus on the clot. Aplar syndrome, use the older agents. We still don't have enough data with the newer drugs when it comes to Aplar syndrome. Monitoring is a challenge, and we don't know how to dose essentially. So what about long-term anticoagulation for secondary patient? I addressed this issue briefly some time ago. Which patient do you give more than 6 months? If the risk of bleeding overweighs the risk of the benefit from anticoagulation, don't give it beyond 6 months. Try to stop anticoagulation. Especially if the factor which caused the thrombosis, for example, bed-bound patient, right? If that provoking factor is no longer present, work towards stopping anticoagulation. They can be more harmful than beneficial. Previously, especially if that thrombosis was uncomplicated. At the same time, remember to give written information on what are the signs and symptoms of a recurrence of thrombosis, and make sure that they understand when to contact you, how to contact you. And based on all of these, factors, especially taking into account the risk of bleeding, using a score like Has-Bled score, right? You take this into account. So remember, when you want to give anticoagulation beyond 3 to 6 months, bleeding is more important than progressive thrombosis, right? So when you want to start anticoagulation, the Wells score, which will predict thrombus, is more important. But when you want to continue it beyond 6 months, bleeding, long-term bleeding, catastrophic bleeding in the community is far more important to be estimated. What if you have a patient who has who fails your anticoagulant therapy and has progressive or recurrent thrombosis? Check, are they taking the right medicine, the right dose, at the right time regularly? Check adherence. Look for other sources of hypercoagulability. And let me tell you one particular patient that I had who had thalassemia. He was a young kid, thalassemia major, who had undergone splenectomy to reduce the transfusions. And because there was splenectomy, there were a lot of NRBCs, nucleated RBCs in the blood. And with hemoglobinopathy like thalassemia, there are fragments of RBCs because of hemolysis. There are fragments of RBC membrane floating in the blood. And these are prothrombotic fragments of RBC membrane. So there was an additional source of hypercoagulability. And this patient would come with recurrent pulmonary embolism. In this case, we had to try to increase the dose of anticoagulant. And in fact, we had to add aspirin to acetylrome to reduce the recurrence of thrombosis. So look at all of these issues when the treatment fails. And that's where I'm going to stop.